To get in the basis of the topic, what is the issue with long gaps of time between receiving a diagnosis for a type of cancer and finally getting that treatment for it? And how long of time are patients experiencing it?
So, particularly in advanced stage cancers, meaning that they've spread beyond the original site, there it's important to know usually a grouping of molecular markers um, that help to determine the treatment. And so, a lot of times patients will have a biopsy. They'll be diagnosed with a lung cancer, for example. Um, the tissue will go off. The doctors call the patient and say, unfortunately, it looks like you've got a lung cancer, but there's multiple types of lung cancer. And particularly in non-small cell lung cancer, there's multiple of these molecular markers or biomarkers that will help to determine what kind of treatment the patient will go on. We try not to delay therapy very long because a lot of times lung cancer patients in particular are very symptomatic from the disease, and we have to start therapy. So we will try to get these biomarkers done as quick as possible, but a lot of times there are gaps because the doctor who diagnoses the patient may be a radiologist, it could be a pulmonologist, it could be a cardiothoracic surgeon, and they will send the tissue off to get the diagnosis, but they won't do the biomarkers because they sort of say, well, that's up to the oncologist, the treating doctor, to do it. And the difficulty is the oncologist sees the patient the first time, and it may take 2 weeks to get in. And then they say, well, unfortunately, Mrs. Jones, it looks like you have, metastatic lung cancer or advanced stage lung cancer, but I don't have any of your molecular markers back. We're going to need to send that off. It can take up to 2 to 3 weeks to get that back. Well, there you go. They're already at a month there. And so a lot of times oncologists will start the patient on a more broad chemotherapy, which sometimes is not the right decision because it could be that one of those molecular markers demonstrates a mutation that there's a drug for it. It's a targeted therapy, and it can lead to better outcomes. There have been studies that have shown that. And it also a lot of times has less toxicity than some of the broader based chemotherapies. But the oncologist is treating the patient that's in front of them, and would love to have those markers back, but it doesn't. And so it can lead to significant delays. And also a lot of time for clinical trials, if the patient wants it, they're very much dependent on those, what are the biologic markers that we need to know to determine if this patient's even eligible for a clinical trial. And we don't have them back. And so that can be a delay. Part of the reason that this is happening is, you've got different treating physicians. You may have a pulmonologist, again, a cardiothoracic surgeon. It could be done in an outpatient setting. The oncologist could be part of a hospital. They could be an independent group. There's lots of different places that the care can be taking place. The other thing is that the pathologist diagnosing the cancer a lot of times may or may not feel comfortable ordering these molecular markers. All of these things, they seem small, but they contribute to these delays. And it requires a lot of coordination of your pathologist, your oncologist, your potentially team that diagnosed the patient to know sort of hey, this is an advanced stage. There are agreed upon markers that should be ordered, and it requires a system in place to sort of get that done in a timely manner. If it's not, and particularly sometimes out in the community, it can be more difficult to do it because there's a lot of fragmentation. The doctor may be affiliated with a different hospital. The clinic that diagnosed the patient could be a different system, and that's where the breakdown can a lot of times occur.
Thank you. Now, you did mention, clinical trials, which can be affected in this delay of care. And obviously, treating patients sooner can clearly benefit their health outcomes by increasing their chances of survival. So, in other ways, can you explain how, or what other areas like cost of care can be improved through shortening this gap?
Absolutely. So, it requires a coordinated system where the patient is being diagnosed biomarkers are appropriately being sent off right at the time of diagnosis in a sort of an agreed upon setting. It can decrease the costs of care by, um, one, if depending on if the patient's going to consider a clinical trial or not, you don't need to do as many biomarkers. So the approved biomarkers for therapy at this point in time, let's take lung cancer, are about 6 to 8 biomarkers that really need to be done to appropriately treat the patient on standard of care. If they're considering a clinical trial, it could be that there are additional biomarkers. Sometimes it can be an additional 50 biomarkers that need to be done. The way that it can improve and decrease costs is, let's say the patient tells you they really don't want a clinical trial. They want to be treated, and a lot of patients, for a variety of reasons, don't want to go on a clinical trial. Then sending off a very large panel that can take several weeks to get back, and would have significant cost, may not be appropriate for that patient. It may be that we really need to just do the 8 to 10 biomarkers that are necessary for standard of care. If the oncologist sees the patient at that point in time and determines that they are a candidate for a clinical trial, because you got to evaluate the patient, see that they're interested, et cetera, it requires the laboratory/pathology group to make the availability of an extended biomarker panel very quick. So, yep, you want to do this clinical trial. It's going to require an additional 150 genes. Do we have the block, of tissue? Can we get it off to the lab? Or, was the way that the original 8 to 10 biomarkers were done really on a larger panel, and it can just be unblinded, and additional analysis can be performed to figure out whether or not the patient has these extended biomarkers for a potential clinical trial. That's the ideal scenario. But, as we talked about before, there's a lot of variability in the system as to how this is done, a lot of different ways of doing this, and it can lead to delays and increases in cost.